Welcome to the deep dive. Today we're really digging into hyperbaric oxygen therapy, or HbO2.
That's right. And you've brought us a key chapter, chapter 9 from Hyperbaric Medicine Practice.
Yeah, focusing on the flip side. When HbO2 might not be the right move, the contraindications and relative risks.
Exactly. Our goal today is to sort of unpack this chapter, get a solid handle on the core ideas behind HbO2, when it's useful, but also, really crucially, when we need to be cautious or maybe avoid it altogether.
Kind of understanding the power, but also the guardrails, right?
Precisely. Understanding the potential and the necessary safety checks.
Okay. And this chapter, it's from a textbook, so it really stresses this is not always simple. Yeah. Doctors have to weigh things up for each patient.
Absolutely. That benefit-risk analysis is key.
So where do we start? What are the fundamental things we need to grasp about HbO2 and why some situations get flagged as risky?
Well, the chapter lays out a few core concepts right at the beginning.
Sure.
First off, breathing 100% oxygen at higher pressures isn't neutral. It can be therapeutic, definitely, but it also carries a potential for toxicity. It depends on that pressure level.
Like a concentrated drug, almost.
That's a great analogy the chapter uses. Very effective sometimes, but you've got to watch for side effects.
Gotcha. High pressure, high oxygen. Needs careful handling. What's the second big idea?
The second one is all about physics, really. Pressure changes always affect gas volumes in the body. Think basic gas laws.
Boyle's law.
Boyle's law is the big one here, yeah.
Yeah.
Pressure goes up, volume goes down, pressure goes down.
Volume goes up, like a balloon inside you, expanding as the pressure drops.
Exactly. And that simple idea is fundamental to understanding a lot of the risks.
Okay, expanding and contracting gas. That makes sense. Now, the chapter says there's really only one absolute no-go, scientifically speaking. What's that?
Right. Based squarely on Boyle's law, it's an unvented pneumothorax.
So trapped air between the lung and chest wall.
Yes, and unvented means it has no way out. When you decompress after the treatment, pressure drops.
And that trapped air expands.
Potentially causing a tension pneumothorax, which is a buildup of pressure in the chest, a real emergency, life-threatening.
Okay, that sounds critical. So trapped gas that can dangerously expand is the main absolute contraindication. What about other risks? The chapter seemed to suggest most aren't so clear-cut.
That's exactly it. The vast majority are described as relative. They might be theoretical worries or based on experience or specific circumstances, maybe even just anecdotes. The authors group them, which is helpful. Risks from trapped gas, risks from the oxygen itself, toxicity, and risks just from the pressure changes.
So how do doctors navigate that gray area, the relative risks?
Yeah.
If there aren't hard and fast rules.
Yeah, it's not like formal, statistically validated guidelines for every single scenario. It's more about, accumulated clinical wisdom.
From experts.
Yeah, expert practice, looking at patient outcomes data, info from equipment makers, published studies. It's a mix.
So using the best available info and being cautious.
Definitely. And the chapter really hammers home that because every patient is unique, you have to do that individual benefit-risk assessment before starting HbO2.
Because we don't always know precisely how much risk a certain factor adds.
Exactly. We often don't know the exact degree of increased risk.
Like trying to predict. Yeah, complex systems. The chapter compared the oxygen to a drug again here, didn't it?
It did. It's a useful way to think about it. Like any drug, 100% oxygen has inherent potential side effects, and sometimes they're unpredictable.
So the doctor weighs, say, saving a limb against maybe causing temporary ear pain.
That's the kind of judgment call involved, yes. Weighing the potential good against the potential harm in that specific patient's situation.
Okay, that sets the stage well.
Yeah.
Now, there was a quick mention of logistical contraindications. These aren't about the patient's body directly.
Correct. More practical stuff like, is the staff properly trained? Is the equipment safe?
Right.
Are there external hazards? Can the patient be transported safely? What about bad weather interrupting things?
Makes sense.
And interestingly, even things like coercion, like a parent insisting on being in the chamber with a child when it's not really indicated.
Ensuring safety and ethical practice all around. Okay, let's get back to the medical side. Absolute contraindications due to trapped gas. We covered unvented pneumothorax. What else is an absolute no?
Another big one is gas inside the eye. Unless it's related to treating decompression sickness, like in divers.
Why is that so critical?
Same principle as the pneumothorax. During decompression, that gas bubble in the eye can expand.
Ouch.
Yeah, it can cause a huge spike in eye pressure, ocular barotrauma. It can cut off blood flow, damage the retina, potentially cause blindness.
Wow. And there are specific gases used in eye surgery.
Yes, the chapter lists common ones: air, SF6, C2F6, C3F8. And importantly, these can take sometimes longer to naturally resorb.
So you really need to know if that gas is still there.
Ah.
Critical point. Anything else in the absolute trapped gas category?
A hollow orbital prosthesis, an artificial eye with an empty space inside.
Why is that a problem?
Reports of them collapsing or imploding under pressure. If it can be removed, it should be before each treatment. If not, HBO2 is out.
Okay. Solid ones are fine, though.
Solid ones are fine, yeah.
Got it. One more.
Yes, acute severe bronchospasm that's not under control. If someone's airways are clamped down, struggling to breathe, the pressure changes could be really bad. They need to be stable first.
Makes sense.
And then there are rarer things listed, like certain lung cysts or pockets in the throat or esophagus where gas could get trapped. Same principle applies.
Okay, so the theme is trapped gas in enclosed spaces that can expand dangerously on decompression. Now let's shift to relative risks, where it's more of a maybe needing extra care. What about trapped gas risks in this category?
COPD, especially emphysema, is a big one.
Because of weak spots in the lungs, blebs and bulla.
Exactly. Those pockets of trapped air, pressure changes could potentially rupture them, cause pulmonary barotrauma.
So you need to screen carefully.
Yes. Chest x-rays, maybe high-resolution CT scans, sometimes specialized lung function tests like an inert gas ventilation scan to see if air is actually getting trapped.
And if you do proceed,
You might use strategies like decompressing very slowly, maybe give bronchodilators beforehand to open the airways, trying to minimize that risk.
being extra cautious with vulnerable lungs. What else?
A recent pneumothorax, even if it's healed. The advice is usually wait about 6 weeks for non-urgent HBO2, let things really settle.
Oh, okay.
A history of spontaneous pneumothorax where it just happens, that's a flag too, because it might happen again, maybe even turn into a tension pneumothorax during treatment.
Right. Higher baseline risk.
Yeah. And previous chest surgery or trauma can cause scarring, potentially trapping air, so that needs consideration. Maybe adjusting decompression rates.
In teeth, you mentioned teeth.
Barodontalgia, tooth pain from pressure changes, can happen with cavities, bad fillings, root issues, cysts, anything that creates a little sealed-off space in or around the tooth.
Huh. Okay, so those are the relative risks tied to trapped gas. What about risks from the oxygen itself? Oxygen toxicity.
Optic neuritis is a key one here, but specifically if it's acute, like a new flare-up, sudden worsening vision.
Not just a history of it, like in MS.
Right. If it's active inflammation, the worry is the high oxygen could make it worse, potentially causing more vision loss. And it's hard to tell if vision decline during HBO2 is the treatment or just the disease progressing.
Tricky. So what do you do?
Definitely need an ophthalmologist involved. Close monitoring of vision during treatment is crucial. But interestingly, for MS patients without active optic neuritis, HBO2 is generally considered safe.
That distinction is important. Active versus history. What else for oxygen toxicity?
Retrobulbar optic neuritis inflammation behind the eye. There's a rare case mention of vision loss with really high HBO2 exposure in someone who already had it.
Okay.
And retinopathy of prematurity. But that's specifically a risk for premature babies themselves, the hyperoxia affecting their developing retinal vessels.
Not a risk for the baby if a pregnant woman gets treated.
No reported risk to the fetus in pregnant women treated at standard pressures. That's important to clarify.
Good. Now, those two specific chemo drugs, bleomycin and doxorubicin, the chapter flagged them. Absolute no.
Actually, no. The current thinking isn't absolute contraindication. It's more of a relative risk if the patient is currently receiving them.
So, requires a careful case-by-case decision.
Exactly, especially if the HBO2 is for something urgent. Prior exposure, having had them in the past, isn't generally seen as a reason to withhold HBO2 now.
What was the original concern?
Some older animal studies hinted at potential heart issues with doxorubicin or lung issues with bleomycin when combined with high oxygen. For bleomycin, things like how recently they had it and the total lifetime dose are factors to weigh up.
So it's nuanced. Less about a definite problem, more about potential interactions and timing. Okay, what about risks just from the pressure changes themselves?
Common ones are acute upper respiratory infections, like a cold and middle ear infections, otitis media.
Because you can't clear your ears.
Right. Difficulty equalizing pressure leads to ear pain, maybe barotrauma.
Makes sense.
Similarly, some types of previous ear surgery, mastoidectomy, stapedectomy, tympanoplasty, can affect equalization or risk damaging implants.
What about other implants? pacemakers.
Yeah, cochlear implants, middle ear prostheses, pacemakers, defibrillators, shunts. They all have potential pressure thresholds specified by the manufacturer.
Yeah.
Going above that could cause malfunction. You have to check the specs.
Essential homework.
And any device that hasn't been tested under pressure is a relative risk. You'd probably avoid using HBO2 with it for chronic issues, but maybe weigh it differently in an emergency.
Okay, so anything sensitive to pressure needs a close look. What about other general medical conditions listed as relative risks?
Unstable congestive heart failure. If someone's having frequent flare-ups, the stress of HBO2 might be too much, outweighing the benefit.
But ejection fraction alone isn't the deciding factor.
Correct. Clinical stability is more important. Uncontrolled seizures are another one, partly managing a seizure in the chamber, partly differentiating it from a rare oxygen toxicity seizure.
Right.
Uncontrolled high blood pressure needs close watching. Chronic respiratory failure with high CO2 levels, hypercapnia. There's a theoretical concern about reducing the drive to breathe. Claustrophobia obviously makes being in a chamber tough. Might need a trial run or medication. And brittle diabetes with hypoglycemia risk needs really careful blood sugar management.
So managing existing conditions is paramount. Now, there were a few other drugs mentioned with weak published evidence. What's the story there?
Yeah, these are ones where there's not strong proof of a problem, but caution is advised. Cisplatin, another chemo drug, is more about potentially slowing wound healing, but HBO2 might still be okay for other reasons.
Okay.
Disulfiram, used for alcohol dependence, has a theoretical risk of more seizures, especially with many treatments. Mafenide acetate, a burn cream, might counteract some HBO2 effects on blood vessels, so maybe use a different antibiotic. Anti-angiogenic cancer drugs designed to stop blood vessel growth could work against HBO2's mechanism for things like wound healing.
Because HBO2 often works by promoting vessel growth.
Exactly. And amiodarone, the heart rhythm drug, has its own known risk of lung toxicity, separate from HBO2. So you'd want baseline lung function tests before starting HBO2 if someone's on it.
Got it. So often theoretical interactions or overlapping side effect concerns. Now, really interestingly, the chapter highlighted things that are not contraindications. Pregnancy was one. That might surprise people.
It often does. But the chapter explains the physiology of the baby's ductus arteriosus normally closes more easily at higher oxygen pressures than we typically use clinically.
And there's actual experience treating pregnant women.
Yes, lots of reports. Significant Russian experience treating women throughout pregnancy for various things like CO poisoning or severe anemia with no signs of increased risk to the baby and sometimes clear benefits. The bottom line is the usual reasons for HBO2 apply.
That's reassuring. What about cancer, malignancy? The fear that oxygen fuels cancer.
That's a common worry, yeah, stemming from some early mixed research. But the chapter points to many more studies showing neutral or even beneficial effects, like making radiation therapy work better.
So the fear isn't really backed up by current data.
Largely no. Big reviews in 2003 and 2006 concluded HBO2 doesn't promote cancer progression and is safe in patients with a history of cancer. The key is that cancer treatment is the priority, and HBO2 shouldn't interfere.
Okay, good to clarify. And glaucoma. Eye pressure again. Is the chamber pressure a problem there?
Surprisingly, no. Glaucoma pressure is from fluid buildup, which is different from gas pressure causing barotrauma. In fact, eye pressure tends to decrease slightly under increased ambient pressure, like in an HBO2 chamber or even diving.
Huh. Counterintuitive. Now, there was that whole section on conflicting data about pneumocephalus. What is that condition again?
Pneumocephalus means air inside the skull, where it shouldn't be. CT scans are best for seeing it. Usually not serious, but can rarely cause dangerous pressure buildup tension pneumocephalus.
And how does air get in there?
Various ways. Head trauma, brain surgery, tumors, infections, diving, medical procedures, CSF leaks, even air travel sometimes. Symptoms range from mild headache to severe things like confusion or coma.
Okay, air in the head. Why is the data on HBO2 so mixed?
It's complicated because pneumocephalus seems to have 3 different relationships with HBO2. First,
It might actually help.
yeah, there's some evidence, like that 2014 Brazilian study mentioned, suggesting HBO2 might speed up the body absorbing that trapped air, potentially reducing complications like meningitis, shortening hospital stays.
Wow, okay. The high oxygen helps clear the air.
That's the idea. But second, there are rare cases where pneumocephalus seems to have been a complication of HBO2, especially after head trauma with a skull fracture and CSF leak.
So the pressure changes could make it worse somehow.
The worry is air gets trapped or re-expands badly during decompression if the leak isn't sealed. And third, Based on air travel cases, it's also sometimes been seen as a reason to avoid HBO2.
So it could help, it could harm, or it could be a reason not to do it. That sounds
Yeah.
messy.
It is. The chapter mentions a couple of theories: inverted soda bottle effect, ball valve mechanism, trying to explain why air gets trapped. But because the data is conflicting and we don't fully get the mechanics in every case,
There's no single recommendation.
pretty much, the chapter concludes no definitive recommendation can be made. It needs really careful case-by-case evaluation.
That really drives home the complexity and the need for individual assessment.
Yeah.
Okay, finally, let's quickly touch on those case examples. They help illustrate things. Case 1. The man with COPD and blood in his urine. Key point.
His COPD, even if seemingly controlled, a past CT showed air trapping signs, lung tests showed mild obstruction. That flags a significant risk for pulmonary barotrauma.
So more tests needed first.
Absolutely. Needed more detailed lung assessment, that inert gas scan, and a new high-res CT before even considering HBO2.
Right. Dig deeper into the lung risk. Case 2. Diabetic foot ulcer, recent eye surgery with a gas bubble. That one was clear-cut.
Totally. Intraocular gas is an absolute contraindication. Stop. Do not pass. Go until you confirm that gas is completely gone. The risk of vision loss is just too high.
No wiggle room there. Case 3. MS, history of optic neuritis, getting HBO2 for bone infection. What was the stop signal?
Worsening vision. Even with the history, any new vision decline during HBO2 has to be treated as a potential treatment-related flare-up. Risk of permanent damage means stopping the HBO2, unfortunately.
Vision changes are a huge red flag there. Case 4. Multiple health issues, including heart failure, considered for radiation tissue damage. Why hold off?
The unstable congestive heart failure, recent worsening episodes. Clinical stability is key, more so than just the ejection fraction number. The risk from stressing the unstable heart outweighed the potential HBO2 benefit.
Manage the unstable stuff first. Makes sense. In case 5, breast cancer patient, non-healing wound, meds, various meds. Which drug was the issue?
The anti-angiogenic drug, Avastin.
Because it works against what HBO2 is trying to do for the wound.
Exactly. It stops new blood vessel growth, while HBO2 promotes it for healing. They counteract each other for that specific indication.
Got it. Those cases really clarify how these principles play out.
They do. They show how vital that detailed history, understanding the conditions, and knowing potential interactions really is.
Well, this has been an incredibly thorough look at the contraindications and relative risks for HBO2. The takeaway seems clear. Powerful tool, yes, but you absolutely need to understand when it's not right or needs extreme caution.
Definitely. That decision always comes down to balancing benefit versus risk for that specific person, looking at their history, conditions, meds, and those core risks: trapped gas, oxygen toxicity, pressure effects.
And it really emphasizes that this isn't something you dabble in. You need specialized knowledge.
Absolutely. Consulting with hyperbaric medicine specialists is crucial for proper evaluation and managing the treatment safely. It's serious medicine.
Couldn't agree more. So here's a final thought to leave everyone with. We see just how nuanced and context-dependent the risks and benefits of HBO2 can be. What other common medical treatments might have similarly complex profiles that demand such careful individual evaluation? It's a good reminder of how dynamic medicine is, right? And the need for constant learning and critical thinking. Thanks for joining us for this deep dive.